Sir, it's 3, 2, 1. We are live now, sir.
Good evening, everyone. I welcome one and all to ProCare AHTs, Midlife CMEs, a scientific platform provided by McLeod's Pharmaceuticals. I am Dr. Sanket Nibale, representing medical affairs at McLeod's. And today, we are here to discuss on the topic evidence-based pole positioning of dapagliflozin in cardiovascular and renal-cardiac space. But before we get into the session, let me tell you a brief about our company. McLeod's. McLeod's is equipped with an experience spanning across 3 decades, has emerged as a global force with a dedicated team of around 14,798 professionally qualified employees worldwide and state-of-the-art manufacturing and R&D setup. We are one of the fastest growing pharmaceutical company in India. With a growing presence in more than 80 countries, McLeod's is now aiming to be a pace setter for the world healthcare. Now, taking to the session, the eminent speaker I've been referring to, who would be taking us through his vast journey of experience and learnings on the topic of diabetes, hypertension, heart failure, and the renocardiac space, is none other than Dr. J C Mohan. Dr. Mohan sir is a consultant emeritus, Fortis Hospital, Shalimar Bagh, Delhi. He has been a chairman, Institute of Heart and Valvular Disease, Jaipur, Golden Hospital, Rohini. President of the Apex Society for CME in Cardiology. Former Professor of Cardiology, GB Pant, Postgraduate Institute of Medical Research, Delhi. He has over 280 papers in indexed journals, written 2 books on echocardiography, contributed to 55 chapters in various textbooks of cardiology, major interest in heart failure and valvular heart disease and imaging. Without any further ado, I would like to welcome Dr. Mohan sir to start his session. Over to you, sir.
Thank you very much, Dr. Sanket, and thank you for inviting me for this important webinar, wherein we would be discussing SGL2 inhibitors in general and dapagliflozin in particular, and its positioning in cardiovascular and renocardiac space. The story of SGL2 inhibitors is a tale of serendipity, ingenuity, and chance. Of the SGL2 inhibitors investigated, dapagliflozin is the most well-studied molecule. And it wouldn't be an exaggeration to say that dapagliflozin has changed trajectory of cardiovascular and renal disease, both in patients with diabetes and those without diabetes. The story started with the fact that SGL2 inhibition causes glycosuria by working on proximal convoluted tubules, and glycosuria would actually reduce the plasma glucose level and hence try to produce a normoglycemia, reduction in hyperglycemia. Along with passage of glucose, we also realize there is diuresis, there is some natriuresis, some uricouresis, and of course, the loss of glucose will result in fat loss because there would be mobilization of fat, and hence it mimics fasting. One would lose weight, and because of diuresis and natriuresis, there is a hypoxia mimicry. And eventually, what we have seen over a period of last 10 years, that drugs, SGL2 inhibitors in general and dapagliflozin in particular, because of multiple metabolic and hemodynamic mechanisms, results in mitogenesis, mitochondriogenesis, enhanced autophagy, erythropoiesis, and reduced inflammation. The end result is organ protection, repair, and regeneration. We also know that diabetes has a long-term bidirectional relationship between heart and kidney, and the common shared pathophysiology is oxidative stress, inflammation, cellular apoptosis, and vasculopathy. All these mechanisms result in cardiomyocyte loss and also nephron loss, and both of these things can be prevented by SGL2 inhibition, and not because of glycosuria, but because of the multiple other ways by which dapagliflozin works. The fact that there is an intimate relationship between heart and kidney is actually proven by this very recent work published just 2 months back, showing a relationship between the kidney function, that is change in EGFR, and the adjusted odd ratio for heart failure. You would see that there is a linear relationship between decrease in EGFR and increase in odds for heart failure, both symptomatic heart failure as well as hospitalized or fatal heart failure. So it's a bizarre but wonderful feeling to arrive dead center of a target you didn't even know you were aiming for. When we were producing glycosuria by these agents, we never thought that we would be having the kind of results which we have seen with these agents. Let's come to the preamble. The fact is that diabetes is a major public health problem in this country, and it has been estimated that about 77 million adults suffer from diabetes in India. And majority of patients with diabetes will develop cardiovascular disease before they die. And majority of patients with cardiovascular disease will develop heart failure before they die. And majority of diabetes with cardiovascular patients will develop CKD or diabetic kidney disease. And the reason obviously is because there is a common soil hypothesis, common genetics, and common environment, which is responsible for type 2 diabetes and atherosclerotic cardiovascular disease. The interface over a period of time is blurring, and we are seeing a large number of patients with diabetes having atherosclerotic cardiovascular disease, and a large number of atherosclerotic cardiovascular disease patients having type 2 diabetes. So the vascular footprints of type 2 diabetes are atherosclerotic cardiovascular disease, heart failure, and chronic kidney disease, also known as diabetic nephropathy. And the overlap between atherosclerotic cardiovascular disease and diabetes is expanding. Currently, it is considered that we in this country have about 20 million people who have both diabetes and atherosclerotic cardiovascular disease. And in these individuals, there are potentially intersecting and discordant treatment approaches. If you talk of true euglycemia, it is present only in 1/4 of patients with cardiovascular disease. Most people with cardiovascular disease have some form of dysglycemia. Data presented in the EASD 2020 meeting just a few months back, called CAPTURE study from 13 countries, 5 different continents, shows that the type of patients, diabetic patient who visit you and me in the clinic, 35% of them have established cardiovascular disease. 32% of that is atherosclerotic cardiovascular disease. And another 14% of these patients are extremely high risk of developing cardiovascular disease. So all in all, there are about 50% patients who either have atherosclerotic cardiovascular disease or are at a very high risk of developing atherosclerotic cardiovascular disease. But when you look at this CAPTURE study, you find that the guideline mandated therapy for cardiovascular protection in diabetes has been given only to 21% of patients, even in 2019. Remember, this is old data from 2019 from 13 different countries, 250 different practices. It tells you that across the world, use of cardioprotective anti-diabetic drugs is very, very low. But another point which we have to keep in mind is that pathways between diabetes and heart failure cross more often, and they cross more often in India. Data from the 4 studies mentioned here at the bottom suggests that diabetes is present in 49 to 60% of all patients with heart failure in this country. The Western world also is seeing an increasing prevalence of diabetes in patients with HFrEF, as you can see in the graph on right side. And currently it is closer to 45%. The newer randomized trials, including Victoria trial and Paragon HF, have 45%, nearly 45% patients with diabetes. So the relative risk of heart failure in diabetes is about 9 times in younger people, but it just drops to about 2 times in older people, 75 years of age and above. So essentially, since in this country there are much more younger people with diabetes, the chances of developing heart failure are much, much higher, roughly 9 times more than non-diabetic individuals. So what happens when these diabetic have cardiovascular disease, be it atherosclerotic cardiovascular disease or heart failure? The effect is that extrapolating data from Europe, people who develop cardiovascular disease and have diabetes, by the time they are of age 60, they lose 12 years of life. That is remarkable. That is a big shortening of life as a result of cardiovascular disease in diabetics. So 70% of deaths in diabetics are cardiovascular, unlike non-diabetics where 70% of the deaths are non-vascular. Data also suggests that younger diabetics have a much higher chance of sudden cardiac death and all-cause death, nearly 7 times more chance of sudden cardiac death in younger diabetic individuals below 50 years of age compared to young non-diabetic subjects. This all is because diabetics go on to develop what we will call as organopathy. The organopathy could be diabetic cardiomyopathy and nephropathy. These are the 2 big organopathies, although retinopathy is another issue, vasculopathy is another issue. So the pathogenesis of diabetic cardiomyopathy and nephropathy is as a result of glucotoxicity, lipotoxicity, mitochondrial uncoupling, and fibrosis via protein kinase C overactivation. Hyperglycemia through glucose and lipid intermediary products results in activation of protein kinase C isoform, which is responsible for changes you see in kidneys and heart in the form of cellular hypertrophy, the development of increased extracellular matrix, inhibition of sodium potassium ATPase, and increased vascular permeability and proliferation. All these things, including the protein kinase C isoform, can be inhibited by SGLT2 inhibitor, resulting in decreased myocytic and nephron hypertrophy, as I would show you in studies later on. We also realized that there is, of course, all this thing about the cardiac disease and renal disease in diabetes, but we also realized with the large number of randomized trials, the 4 trials, the meta-analysis of 4 trials mentioned here, that the intensive glucose control does not decrease cardiovascular mortality, does not decrease actually stroke. There is some decrease in myocardial infarction, largely because of UKPDS study in which this was early onset diabetes, or rather diabetes being treated early, and you did have some decrease in myocardial infarction. However, There was no effect of intensive glycemic control on all-cause death, cardiovascular death, or stroke. The so was true for heart failure. There was no decrease in incident heart failure in these 35,000 odd patients simply because you had intensively treated dysglycemia. The intensive glycemic control did not make a difference to the frequency of incident heart failure. And that is really strange as well as disappointing. So we got this message that intensive glycemic control cannot put scrambled egg back in the shell in patients with atherosclerotic cardiovascular disease, and none of these conventional anti-diabetic drugs are going to be cardioprotective. However, the fact is cardioprotection in diabetes has been suboptimal despite lifestyle modifications, statins, aspirin, and anti-RAS agents, and we have been looking for newer agents which could provide cardioprotection as well as renal protection. We also realized over a period of time, as I showed you the data, that heart failure in diabetes is a much bigger challenge than atherothrombosis. And this data is coming from all over the world now that heart failure has become #1 manifest cardiovascular complication of diabetes, and atherothrombosis, both myocardial stroke occupy second and third place. So we'll talk about dapagliflozin. That was the preamble about diabetes, cardiovascular disease, renal disease, and heart failure. The data the things which we are going to talk are also relevant to other SGLT2 inhibitors, but we are focusing on dapagliflozin. And we will actually talk about the context, therapeutic matrix, and favorable data with dapagliflozin. I already told you that glucouresis leads to osmotic diuresis, natriuresis, calorie loss. And of course, because of that, there is a weight reduction, blood pressure reduction, mobilization of visceral fat. At the heart level, many things happen. Some of these are good, some of course neutral. Reduction left ventricular mass, reduction diastolic wall stress, favorable energy kinetics, improved mitophagy and erythrocytosis. So finally, what happens is that we have realized dapagliflozin is a multi-dimensional eumetabolic agent which provides cardioprotection and renal protection. Where is the data? Let me just show you the data. But before I show you the randomized data, even when phase 2b and phase 3 trials for safety were being done, it was shown that SGLT2 inhibitors do decrease major adverse cardiac events, heart failure, cardiovascular death, and all-cause mortality. This was based on all the SGLT2 inhibitors lumped together when phase 2b and phase 3 trials were done. And of course, mechanisms, we probably would go back to the mechanisms, but one of the things which we realize is the SGLT2 inhibitors in general actually decrease the hypoxic stress on heart and kidney by fuel efficiency. So what kind of data do we have with dapagliflozin? We have data for primary prevention in diabetes, largely through a big randomized study called DECLARE or TIMI58. We have also data of secondary prevention. Again, part of the DECLARE study was secondary prevention, 40% of that. We have data in heart failure with reduced ejection fraction, and the study named DAPA-HF. Data in diabetic kidney disease with DAPA-CKD. In patients with left ventricular hypertrophy data, DAPA-LVH, and we have, of course, an ongoing study called DELIVER, in which we are actually looking at the benefits of dapagliflozin in patients with heart failure with preserved ejection fraction. So let's come to the DECLARE study. The DECLARE study was a study of 17,000 patients. 60% of these were high-risk patients and 40% atherosclerotic cardiovascular disease. The primary endpoint of non-fatal MI, stroke, and cardiovascular death, although did show a trend in favor of dapagliflozin, wasn't statistically significant. And that, but when we did a sub-analysis or subgroup analysis, we found that patients who had prior myocardial infarction definitely had a 3-point MACE reduction of 16% compared to people who did not have prior myocardial infarction. So one thing was certain, those who had suffered from a vascular event were benefiting from use of dapagliflozin. The co-primary endpoint of DECLARE was also cardiovascular death and or hospitalization for heart failure, first hospitalization for heart failure. And here in DECLARE study, dapagliflozin was positive. There was 17% reduction in primary endpoints of cardiovascular death or hospital for heart failure. And that showed superiority of dapagliflozin over conventional anti-diabetic therapy. What was more impressive was that there was a 27% reduction in hospitalization for heart failure, although cardiovascular death wasn't affected to a great extent. So what we learned was that this could be an anti-heart failure drug in all patients with diabetes, because we are talking about the whole trial of 17,000 patients had 60% patient who did not have established atherosclerotic cardiovascular disease. So in DECLARE TIMI 58, we also realized one thing, that those people who had definite heart failure with reduced ejection fraction, these people had a reduction primary endpoints about 38%. There was a trend in favor in those people who did not have, who had non-heart failure, heart failure with undetermined ejection fraction, but certainly HEFRA patient did show significant benefit with the dapagliflozin. Cardiovascular death also in those with the heart failure with reduced ejection fraction was significantly reduced. Remember, we are all talking about subgroup analysis of DECLARE study. And compared to non-heart failure with reduced ejection fraction, which wasn't affected. So when you lump the three studies, the EMPA-REG outcome, DECLARE, and CANVAS, the three studies with different of these drugs, SGLT2 inhibitors, which were initially introduced to India, one thing was certain, that patients who benefited with regard to 3-point MACE reduction, death, MI, and stroke, were those who had pre-existing atherosclerotic cardiovascular disease. The benefit wasn't very big, it was modest, 14% reduction, but individuals who did not have atherosclerotic cardiovascular disease, on this forest graph, you would find there was no benefit of SGLT2 inhibitors. However, regardless of what patient, whether the patient had atherosclerotic cardiovascular disease or not, hospitalization for heart failure or incident heart failure was significantly reduced by all SGLT2 inhibitors, including the recently concluded VERTI-CV trial, which showed a 30% reduction in hospital for heart failure with ertugliflozin. So very uniform, about 30 to 35% reduction in incident heart failure with SGLT2 inhibitor. And that showed the promise that this could be a drug to be used in patients with heart failure. The systemic review of all SGLT2 inhibitor trials did show again the same thing, that whether patient have with pre-existing heart failure or no heart failure, the benefit with regard to primary endpoints of heart failure was very similar. There was another important exploratory or secondary endpoint, and that was hard renal outcome, which was reduced 45% when all these SGLT2 inhibitors were meta-analyzed. And remember, 60% of these patients had atherosclerotic cardiovascular disease, but 40% did not have. But the renal outcome was favorably altered in all patients, regardless of whether they had atherosclerotic cardiovascular disease or they did not have atherosclerotic cardiovascular disease. Based upon this data, European Society of Cardiology 1.5 years back suggested that SGLT2 inhibitors should be used as a class 1 recommendation, class 1A recommendation for for SGLT2 inhibitors in diabetics with very high risk or those with pre-existing atherosclerotic cardiovascular disease, and the drugs could be given even before starting metformin in case patient is not already on metformin. That was a big leap forward for SGLT2 inhibitors, including dapagliflozin. But I told you the story that we were looking at whether dapagliflozin-like drugs could work in heart failure. For that, a trial was done, which is called DAPA-HF. DAPA-HF actually is a study of 4,744 patients with heart failure with reduced ejection fraction, largely class 2 and 3, well stabilized, mostly on more than 90% patients on anti-RAS agents, beta blocker, 70% on MRA, very well treated, extremely well treated. And nearly 30% of these people were on devices like ICD and CRT. So standard of treatment, the best treatment was they were already on, and then these were randomized to dapagliflozin 10 milligram versus standard placebo therapy. The DAPA-HF trial, as I said, showed a very significant reduction in primary endpoint of cardiovascular death or hospitalization for heart failure of 26% within 18 months of follow-up, and the number needed to treat was 21, clearly indicating that the drug is very, very powerful anti-heart failure drug, even in patients who are extremely well treated. But remember, 42% of these people had diabetic, and 58% to begin with did not have diabetes. And at the end of the study, it was 45 and 55%. So the nearly half of the patient, or more than half patient, did not have diabetes, and they also benefited to the same extent. The interesting part was that the hospitalization for heart failure in DAPA-HF trial, which is an important metric of success of the drug, was reduced by 30%, and number needed to treat was 26, extremely impressive. There was a 17% reduction in all-cause mortality in DAPA-HF trial, and this kind of mortality reduction has been seen with beta blockers, with ARNI and MRA. So now you have a fourth line of drugs which show reduction in all-cause mortality of very significant magnitude. And keep in mind again the same thing, that the patients were both diabetic as well as non-diabetics. The net benefit, when you try to look at the number needed to treat in heart failure, the impressive part was that those who were hospitalized within the first 12 months, they got a much larger benefit. You just had to treat 10 patients for one to get benefit. But people who were never hospitalized, number needed to treat was 44, still very, very impressive. Remember, for primary prevention, when you give rosuvastatin, the number needed to treat is closer to 90 than to this kind of number. Extremely gratifying results of dapagliflozin in patients with heart failure with reduced ejection fraction. The benefit actually came up very quickly within the first 100 days, and on 28th day became significant. So within 4 weeks, you saw that there was a positive benefit of dapagliflozin in heart failure. And as I said, there were more than half of the patients who did not have diabetes, and DAPA-HF showed similar kind of benefit with regard to cardiovascular mortality and composite outcome, whether patient had diabetes or they did not have diabetes. The baseline HbA1c did not make a difference to the endpoints, and the mauve line shows you, regardless of the HbA1c, which is shown on x-axis, the benefit was very, very uniform in all patients. The EGFR level also did not make a difference. People who had EGFR below 60 and those who had above 60 got similar kind of benefit with regard to reduction in hospital for heart failure and cardiovascular death with dapagliflozin. Etiology did not make a difference. Whether this patient had ischemic heart failure, non-ischemic heart failure, they had similar kind of benefit with dapagliflozin. It didn't make a difference whether patients had elevated NT-proBNP levels or rather mildly elevated. In fact, the data suggests a trend towards greater benefit in those who have mildly elevated NT-proBNP, and that is extremely interesting. Normally, you try to add a drug only when patients continue to be symptomatic despite A, B, C, that is anti-RAS agent, beta blockers, and mineralocorticoid receptor antagonists. However, this kind of data suggests that you should add on dapagliflozin in HFrEF patient much earlier, even if they are not much symptomatic, even if they are very well controlled, because there is a 57% reduction in events in those people who are anti-proBNP very mildly elevated, extremely satisfying result. A similar kind of work was published called Emperor Reduced by Dr. Milton Packer and presented actually in ESC a few months back, called Emperor Reduced. And when you compare DAPA-HF, that is dapagliflozin with empagliflozin HFrEF, you realize that the primary endpoints are very similar. Hospitalized for heart failure reduction, very similar, but cardiovascular death is reduced more by dapagliflozin compared to empagliflozin. And this is a point which needs to be discussed because death reduction wasn't significantly reduced by empagliflozin, but was reduced significantly by dapagliflozin. Many people believe that it may be play of chance or it does not show much of heterogeneity, but this is something which we need to keep in mind that dapagliflozin did show a decrease in cardiovascular death and all-cause mortality, which was statistically significant. Based on the data which I have shown you, just this month itself, the American College of Cardiology and American Heart Association, Heart Failure Society of America, came out with a consensus expert panel advisory, which says that people with heart failure with reduced ejection fraction, those who are anti-RAS agent, beta blockers, and also on diuretics, the next step actually after decongestion should be adding aldosterone antagonists as well as SGLT2 inhibitors, primarily both dapagliflozin and empagliflozin. So the moment these people achieve the maximally tolerated dose of anti-RAS agent beta blocker, these patients should be on dapagliflozin, and which is a very big news for patients with HFrEF. The fact is dapagliflozin also reduces the new onset occurrence of new onset diabetes, and here is data from DAPA-HF in non-diabetic individuals showing a 32% reduction in new onset diabetes with the dapagliflozin. And I did talk to you about the fact that 2/3 of diabetics have left ventricular hypertrophy and hypertrophied hearts fail and fibrillate. DAPA LVH trial shows not only dapagliflozin reduces inflammatory markers, insulin resistance, visceral fat, and subepicardial fat, it also decreases the left ventricle mass in those individuals who have controlled blood pressure. And this data is from with cardiac MR and hence is very, very robust, significant at the end of 6 months. Why is this important? Because left ventricle, 2/3 of the patients with the type 2 diabetes have left ventricle hypertrophy or thick walls or increased left ventricle mass. It's only 34% people who have normal left ventricle mass. So regression of left ventricle mass with dapagliflozin also is one of the mechanisms of reducing hospital for heart failure, improving systolic and diastolic function. And this is something which we need to keep in mind. Why? Because hypertrophied hearts fail and fibrillate. If you reduce hypertrophy with dapagliflozin, you definitely are going to prevent heart failure and death. The other trial, which is of great significance to all of us, is DAPA CKD study, which was a study of 4,300 patients, people who had actually largely stage 3 or more of CKD with significant albuminuria with the 200 to 500,000 milligram per gram of creatinine. And this study again in these patients with diabetic kidney disease showed a 39% reduction hard renal endpoints like end-stage renal disease, doubling of serum creatinine, renal or cardiovascular death with the use of dapagliflozin. End-stage renal disease were reduced by 41%, cardiovascular death or hospitalization were reduced by 29%, and all-cause mortality in these patients were reduced by 31%, suggesting that for renal protection, dapagliflozin is an extremely potent drug. Not only it benefits the heart, it simultaneously benefits the kidney. Because remember, people with nephropathy are at a high risk of developing heart failure I already showed you the data. So one of the important things which we have learned so far is that adding SGLT2 inhibitor to regular treatment of have heart failure with reduced ejection fraction is going to further reduce mortality, both all-cause and cardiovascular mortality. Renal protection has been something which we did not have any significant drug except the anti-RAS agents, and now of course Finrenon is being talked of. But the data from DAPA-HF did show a slower decline of eGFR with dapagliflozin. And when you put all SGLT2 inhibitors together, and you would see that at the end of 6 months or so of continued use of SGLT2 inhibitors, reduction in eGFR is much slower, or rather becomes stable when you use SGLT2 inhibitors compared to other glucose-lowering drugs, clearly suggesting prolonged renal protection with this drug. All these studies put together again are showing that regardless of the baseline eGFR, whether in DECLARE, which was 85, or DAPA-CKD, which was about 44, the patients benefit with regard to the hard renal endpoints. And patients benefit whether this is a diabetic CKD or non-diabetic CKD. The blue arrows show you the benefit, the extent of benefit, which is nearly 50% in non-diabetic and about 40% in diabetics, and overall again 40%, again suggesting that everybody who has CKD benefits from dapagliflozin, whether they have diabetes or they don't have diabetes. So ladies and gentlemen, I have taken you through the entire gamut of dapagliflozin, its mechanism, its dose, where to use, how to use, and the entire cardiovascular space, atherosclerotic cardiovascular disease, heart failure, HFpEF, left ventricular hypertrophy, hypertension, and also through the entire cardiorenal space. So in 2021, whenever you see a patient with atherosclerotic cardiovascular disease, CKD, DKD, or heart failure with reduced ejection fraction, somebody who has diabetes, ask yourself a question. And that question is, why is this patient not on dapagliflozin? This question needs to be asked because you need to be proactive rather than reactive to protect heart and kidney of all your patients who have diabetes. Thank you very much.
Thank you, sir, for the lucid presentation. I think the journey of SGLT2, the way you have given us, I think it opens the mindset of how a drug, which was, or rather, which is, I would say, more close to an ideal drug for even diabetes, or now as non-diabetics can also benefit from it. I think the way you have positioned it and the way you have taken us through the journey was really an exciting. And I think until we wait for questions, I think I'll request everyone who the attendees to post his or her question in the chat box so that we can take it with Dr. Sir. Sir, until the questions appear in the chat box, would it be, I request your permission to ask a few questions from my end, sir.
Please go ahead.
Thank you, sir. So now dapagliflozin amongst the SGLT2 is the only drug which has gone off patent, and hence there is a lot of usage that we can see in the coming future. But if I may ask, would you position, or how would you identify which SGLT2 for which patient? Is there any criteria as such, or every SGLT2 is similar, sir?
So the first and foremost thing you need to treat patients by way of evidence. You must have evidence. The evidence, largest amount of evidence actually is available with the dapagliflozin. Now, how do we know that? We have data in diabetic and non-diabetic heart failure, diabetic and non-diabetic CKD, patient for primary prevention, for which of course that kind of data is not available with empagliflozin. Is data there with canagliflozin to some extent, and secondary prevention data which is there with all the drugs. The reduction in left ventricular mass, the data is available with empagliflozin as well as dapagliflozin. If you strictly go by the evidence, then these are the two drugs. We also feel that because dapagliflozin did show a decrease in mortality, both all-cause mortality and cardiovascular mortality in heart failure, even though these patients were less sicker than those in emperor reduced, tells me, and also the very impressive data that even people with mild heart failure draw much more benefit dapagliflozin. Of course, we need to understand the mechanism, and one could actually argue that this is a class effect, so it doesn't make a difference whether you use dapagliflozin, empagliflozin. But the data is much more convincing with dapagliflozin than with empagliflozin at the moment, as far as heart failure is concerned and kidney disease is concerned. As far as reducing cardiovascular death is concerned, because the empiric outcome, I do agree the atherosclerotic cardiovascular disease, one might be tempted to use empagliflozin. But dapagliflozin has one big advantage, and that advantage obviously is, as you rightly said, having gone off patent and now actually being made available in combination with other anti-diabetic drugs at no additional cost. Plus the fact that that kind of combinations are going to reduce the myocardial infection, which remains an issue, and of course reduce the euglycemic ketoacidosis, which remains an issue with dapagliflozin as well as empagliflozin. Having said that, no single molecule will ever have actually monopoly. Physicians have to believe in the data. They have to have their own conviction about a molecule and use it. And the same thing is true for whether you are talking of losartan, valsartan, telmisartan, olmesartan, azilsartan, ramipil, perindopril, enalapril. People use whatever they feel. But the fact is it should be used. Such molecules should be used. And now the dapagliflozin available that cheap, you can't get cheaper than this, and it has maximum evidence. Why would you use another drug? I don't find any reason. It is possible a year down the line, empagliflozin comes at the same price, and EMPA kidney data comes up, which is similar to DAPA CKD. Then I would say, well, both are equivalent. Choose yourself. You could use both the drug 50-50, or you could just go on one side. Those are issues which are not purely scientific. They are mostly depending on your relations and what kind of experience you have got with the drug.
Great. So I think that answers it comprehensively. So in terms of ARNI, which is the next, or rather, I would not say competitor, but it's like a hands-on with dapagliflozin in heart failure patients. How do you position ARNI and DAPA in heart failure, sir?
So the prior use of ARNI was there both in DAPA-HF, about 11% and about 19% in emperor reduced. Regardless of the ARNI, the benefit was of same magnitude. But both the drugs have some diuretic effect, some natriuretic effect. So the big advantage of actually dapagliflozin is doesn't cause hyperkalemia, doesn't cause angioedema, doesn't cause hypotension. So 25% of your patient wouldn't tolerate any dose of ARNI. We know it. I mean, our own experience. Those are the people straight away, you can start with dapagliflozin. Hyperkalemia is an issue. You have to get out of this thing. And the more is the CKD, more is the chance of hyperkalemia. And those are the patients where SGLT2 inhibitors will score over ARNI. But remember, we still have to find out, we still have to have more data, or maybe a randomized study, or maybe a cluster randomization, or maybe a real world experience to say, okay, these are all patients who are on ARNI and now they are on dapagliflozin or not on dapagliflozin. What kind of difference it made? 11% or 19% of all patients, all the patients heart failure on ARNI is too small a number. After all, what is 19% of 3,500 patients, 700 patients? You can't really be you can't have conviction, strong conviction. But my own feeling is this is an incremental and synergistic action. There is a lot of similarity with regard to renal protection with ARNI and DPP4 inhibitor. But ARNI has the issue of blood pressure reduction and also hyperkalemia and of angioedema are big issues. We also, of course, are trying to understand if the if at all the dapagliflozin comes out to be a winner in HFpEF, then it scores over every other drug.
That's true. So that would be a game changer for empagliflozin if it happens. Right, sir. So now, taking towards the next bit from your answer itself, the part that you mentioned about the combination with SGLT2, which are already there in the market, and with DAPA, the DPP4 inhibitor combination, the two options that we see is the vildagliptin and the telinagliptin. So, any opinion on which one would be best suited, or what would be your comment on it, sir?
I will find it tough to say which one to choose, but since dapagliflozin is given once a day, you should give a once a day DPP4 inhibitor with that, and obviously teneligliptin will become a closer to that, because the moment you make it twice, then the big benefit gets lost actually of giving it once a day. The other point is that we do believe SGL2, although the DPP4 inhibitors, some have shown increase in hospital for heart failure, others haven't shown. But by and large, people do believe that, and of course, the box warning is that all of these should be used cautiously in heart failure. When you combine with SGL2 inhibitor, that caution actually you can be a little liberal with that caution, and so you would be two things which make the combination more rational is reduce hospitalization for heart failure because of the combination, and reduce myocardic infection because of the mechanisms, which of course one can discuss multiple ways, better control, or maybe the DPP4 enzymes of the bacteria and viruses being inactivated by the drug. Any which way you see, once a day with once a day DPP4 inhibitor, twice a day with a twice a day DPP4.
Perfectly said, sir. So we have a question in the chat box. It says, so do we need to monitor creatinine of patients on DAPA, as there is a rise in creatinine initially, and later on the creatinine levels lower down? So do
You
we need
should
to monitor?
always actually monitor it, because sometimes some people can develop acute creatinine injury, although it is very uncommon, but more so in patients who are on multiple drugs which are capable of causing potential renal injury because of lowering the blood pressure. And so immediately after acute decompensation for heart failure, you have to be careful. You should measure, you should look at the creatinine, and maybe in these people, you might have to look at creatinine once a week to make sure that the creatinine is not going too low down, where you may have to modify pre-existing drugs. And especially we also know that ARNI has the same thing, ACE inhibitor have the same thing. So when you are combining the two, you probably would have to make sure that you don't give both these drugs together within a week. And in case you are giving within a week, more intensified renal monitoring would be required.
Sure, sir. So I think he must have got the direction that it should be at least once a week until things stabilizes. So we have another question from Dr. Mane, who wants to ask you, do dapagliflozin cause convulsion?
I haven't read about it. I haven't seen any patient. I use a lot of dapagliflozin, but in case it has happened, I can't actually make an explanation. I can't give an explanation, to be honest.
Sure, sir. Sir, talking about dapagliflozin and the new talk of town, which is diabetes reversal. Now, the morbid obese patients who have a high risk or on the early stages of diabetes, with dapagliflozin, we also understand about weight loss. We also understand about DAPA, promoting weight loss at the same time also moves from glucose to ketosis, and the benefits reaping accordingly. So, do you see tomorrow dapagliflozin would be a drug of choice, or probably the drug of best choice for these early pre-diabetes or early diabetics?
And data is promising, as I already showed you from the DAPA-HF data, 32% reduction in new onset diabetes. Mind you, in Emperor Reduce also there was, but it was non-significant 14%. And we don't know the mechanism, why we don't know the reason, but we know that the DAPA is a little less selective compared to empagliflozin, but more than twice benefit, although there's no head-to-head comparison. We have to accept they both does cause it, but DAPA has stronger data. And I think they're very encouraging data to suggest that like you use pioglitazone, like you use metformin, like you could use a drug like dapagliflozin also from pre-diabetes going on to stage of diabetes.
Great. Sir, another question which falls in the part where you have been a great researcher, you have more than 200 publications. Sir, what would be the mechanism of action of DAPA, wherein in non-diabetics it has shown benefits like in the DAPA CKD and the DAPA HF? Because I think one would be glucotoxicity in diabetes, but what about the non-diabetics, sir?
So the actually Dr. Milton Packer and his group from Texas have come up with a hypothesis. The hypothesis says that through multiple enzymes, the SERT enzyme and other enzymes, and these drugs actually produce hypoxia mimicry and fasting mimicry. End result is there is enhanced autophagy of dying cells, so there is better regeneration. There is increased mitochondrial biogenesis and increased mitochondrial mitophagy, which means dead mitochondria and dysfunctional are taken away and new mitochondria come up. Also, erythrocytosis, which happens, improves the oxygen delivery and relieves the ischemia of kidney and heart. And also because of multiple, and also the drugs have action on multiple other enzymes other than SGL2 protein. And sodium hydrogen exchanger has been, 3 has been proposed as one of the enzyme. Protein kinase C has been proposed another enzyme. And so, and about 30% increased ATP production because of SGL2 inhibitor by the even normally functioning diabetic kidney and heart is another mechanism. There are multiple mechanisms. Actually, also, the many people believe that the drug work by actually improving the calcium sensitivity in the intracellular level, and hence calcium works better and produces more actin myosin binding and relaxation. Many mechanisms are there, certainly.
Wonderful, sir. So we have a question from Vivek Tripathi, sir, who wants to ask, do you feel dapagliflozin will score over sotagliflozin in the years ahead?
Definitely, because the SOTA is less well tolerated. You saw the data from SOLOIST, WHF, and SCORED. There is more diarrhea and more hypotension with sotagliflozin. Now, the sotagliflozin will be tolerated less often. And unfortunately, both SOLOIST, WHF, and SCORED had to be terminated prematurely because of COVID. But diarrhea is a big issue. 5% diarrhea, I think you probably going to stick to dapagliflozin, which at least does not cause diarrhea and causes less hypotension.
Sure, sir. Great. Sir, any comments for the new prescribers who are attending today for use of dapagliflozin in special populations, sir?
I would say don't be afraid. Just go ahead and prescribe. Face the bull, actually. Be proactive rather than reactive. Don't keep waiting. Help your patient. Your patient would be helped within few weeks, whether it is kidney, it is heart, or it is heart failure. The benefit, you don't have to wait for months and years. The benefit comes within few weeks and few days. Help your patient. Your patient will live longer, live better. So be active, be proactive, and do it fast. The side effects are more imaginary. Actually, mycotic infection, the only real thing which happens in 3, 4, 5% cases, you forewarn your patient, tell all the precautions, and everything will be all right. In the randomized trial where forewarning was done, mycotic infection just 2, 3%, which is not too much of a problem. Those are my suggestions to people who are starting it. Go ahead and do it. Go ahead and start that drug at least. Experience it. Find out how your patients are benefiting. Don't be reticent. Don't keep thinking that is my last choice, or that key opinion leader said that wait, there are big issues, or somebody will say, oh, there's a 25% mycotic infection, or frail people don't tolerate. There's no data in old people. There's no data in Indians. A lot of these ridiculous suggestions are given. I would say go ahead and help your patients. There is enough data of safety and efficacy. Just go ahead and use it.
Wonderful, sir. Sir, about something which the physicians are scared of when it comes to DAPA is, as you rightly said, a few amount of mycotic infections. Now, if there is a case of mycotic infection identified, what would be your recommendation to stop the SGLT2 or to continue the SGLT2 and continue the treatment of the infection too?
No, so if it is a mild to low moderate, continue and of course give antifungal drugs, both local and of course oral. But is severe infection or recurrent infection, I probably wouldn't. Severe, I will stop it, treat, then restart. But if the recurrent significant mycotic infections, I probably would have to give up on SGLT2 inhibitor. That would happen in about 1%, not more than 1%. My experience, I have been using it for, this is the 5th year I have been using these drugs. I'm quite satisfied actually.
And sir, once you stop it, treat the treatment, treat the infection, and then again start
Absolutely. I do it regularly. Sometimes, of course, I don't know. I have no definite reason to do that. I change. To actually hoodwink the patient, I will change the type of gliflozin.
Sure, sir. And so lastly, about the CKD patients, when it comes to dapagliflozin, it's been studied now in the latest CKD trial until 30 ml eGFR. So anyone who is having 30 or below, shall we not give DAPA, or your comments?
So my threshold at the moment is up to 20 ml. We know that in DAPA CKD it was 25 ml. AMPA kidney is going on, it is at 20 ml. So they haven't stopped it prematurely. So certainly up to 20 ml, there is no problem. And of course, we could use it. Up to 20 ml, I'm using it. I have no problem. And below 20, I would wait for more data.
Perfect. So there has been upcoming trials on dapagliflozin and the steatohepatitis. So any of your patient who got benefited in your treatment, sir?
I actually put a large number of these people on this drug, and I hope. I haven't done any MR. I don't believe in actually ultrasound, although I myself am a big ultrasoundologist. This fibroscan, I do a lot of it. But I put them, and I think we need to start seeing this patient more regularly, get their fibroscan done. Remember, fibroscan is expensive stuff. You can only do research. But the research has clearly shown that the non-alcoholic fatty liver disease is reduced by these agents. I continue to use them.
Perfect. Thank you. Sir, I don't see any more questions coming in the chat box. So hence, I would like to officially, sir, thank you, sir, for your wonderful and enlightening session today. I'm sure the listeners would have gained deep insights in managing the patient better with more confidence today after listening to you, and getting your guidance would really help them get better patient outcomes. Sir, we at McLeods would like to honor your vast experience and your kind heart to share the same on such a platform for the benefit of all the current and the future listeners.
Thank you. Thank you very much. See you some other time. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you.